Let me introduce you about our speaker for today, the resource person, Dr. Thambi Pillai Peranantharajah, the senior consultant physician joining all the way from the Jaffna Teaching Hospital. I warmly welcome Dr. Peranantharajah on behalf of all the participants here. So regarding our lecturer, let me give you a brief introduction. So Dr. Peranantharajah obtained his primary medical degree from the Faculty of Medicine, University of Jaffna in 1992 with flying colors, and his academic career is glowing as we go through his track record. After obtaining his primary medical qualification, Dr. Peranantharajah has obtained MD Medicine degree in the 1999 from the Postgraduate Institute of Medicine, Sri Lanka, and he completed his overseas training program under the supervision of Professor Gavin Becker, a senior consultant nephrologist at a very distinguished and an esteemed center in Australia, that's Royal Melbourne Hospital. Having completed his overseas training, Dr. Peranantharajah obtained his board certification in Sri Lanka, and since 2002, he has been serving as a consultant physician till date at the teaching hospital, Jaffna. And regarding the positions that our guest speaker today has held, among many of those positions, he is a life member of the Jaffna Medical Association as well as the Ceylon College of Physicians. And also Dr. Peranantharajah was a member in the Nephrology, Urology and Transplant Society in Sri Lanka. And also he is a board member in Cancer Aid for Northeast Jaffna. Not only as a clinician, but as a very good researcher, Dr. Peranantharajah has excelled, and he has developed a study designed to assess the cutaneous complications in renal transplantation recipients in Sri Lanka. And also he has published many peer-reviewed articles in established and well-recognized journals all over the world. And he has special interest in renal medicine as well as in dengue fever. And his active participation in the dengue workshop in Queen Sirikit National Institute of Child Health in Bangkok, Thailand in 2014 was highly recognized. And he has already published about 20 case studies in various journals. And not only that, he has contributed to the medical education of our country. He's an external examiner for MD medicine exams as well as MBBS exams. And he's a visiting lecturer in the Faculty of Medicine, University of Jaffna. And also he has been a member of the Board of Study Medicine at the Postgraduate Institute of Medicine, Colombo, since 2004. So once again, I welcome all of you to join till the end of this excellent presentation regarding leptospirosis. Sir, over to you to deliver the lecture.
Very good morning. Thank you very much for giving the opportunity to deliver the lecture today. That common topic, important topic in Sri Lanka, leptospirosis. Leptospirosis in Sri Lanka, we have a lot of communicable disease, mainly dengue fever, leptospirosis, scrub typhus, melioidosis, and leptospirosis. Therefore, anyone come to the acute febrile illness, we should differentiate and find out exactly what is the diagnosis of the fever, and it is important to prevent death. Therefore, everyone should know one of the important disease in Sri Lanka mainly affect in southern part of the Sri Lanka and north central province. Mainly it affects the farmers, mainly in young age. Therefore, everyone should know the leptospirosis, the clinical features and investigation and management plan. Now we start. Leptospirosis is one of the most important zoonotic bacterial disease worldwide, commonly affecting resource poor population and resulting in significant morbidity and mortality. Now we go through one case, right? 40 years old man from Jaffna, history of fever for 5 days and progressive short of breath and dry cough, myalgia, mainly in the legs and thigh region as well as back. pain. He also complained right hypochondrial pain and history that he had recent visit to Kadragama and had a river bath. On examination, looks ill, febrile, conjunctival injection, and muscle tenderness and mild icteric. On examination, further, he hemodynamically stable. On respiratory system examination, bilateral occasional crepitation. Abdomen shows mild tender hepatomegaly. Neurological system, no abnormality detected. Investigation revealed neutrophil leukocytosis, low platelet, high ESR, and the range liver function test on chest X-ray, bilateral non-lobe in distribution of respiratory lung infiltration. That's right. Bilateral non-lobe in distribution and have marked tendency towards the peripheral lung shadow on chest X-ray. What is the diagnosis? The clinical pictures more favor yes, exposure in the river water and most likely leptospirosis. Now we go through what is leptospirosis, when do you suspect lepto, what are your differential diagnosis, what investigation are going to do in this patient or anyone with the acute febrile illness, how are you going to manage, right? What is leptospirosis? It's a zoonotic infection transmitted from animal to human caused by Leptospira interrogat. It visualized by dark ground microscopic body fluids, mainly in tropics, infection of wild and domestic animals. It's a carrier mainly rats as well as dog, rodents, cattle, pigs, anything can transmit that disease. Usually these are the carriers in the proximal tubular part of the kidney occupied this organism and excreted with the urine, and urine mixed with the muddy water or any water can spread the infection to human. Usually this organism can survive up to 3 to 14 days in the environment. Therefore, anyone contact history of places where the rats population high or worked in muddy water or have a bath in river prone to get this infection. Infection usually human occurred incidentally by contamination. Outbreak in flood, high rodent population. In Sri Lanka, we had a high outbreak around 2006. Almost 7,400 people are affected. They are notified as a leptospirosis. Out of that, 204 deaths occurred that time. The case fatality rate is very high, around 2.7. Compared to dengue, it is very high. We should focus on management of leptospirosis, very important. The young population, earning population, mainly farmers, we have to manage properly. This is a microscopic view. The spiro is spiral appearance in dark illumination. Transmission, it is common among the rural farming population and impoverished urban and semi-urban population, particularly affecting young male adult. Farmers, those in contact with livestock, those exposed to rodents at their workplace, and people living in area where sanitation is poor are at highest risk. Recreational exposure in those undertaking water sports has also been described. Urban outbreak are the common in setting where sanitation is poor and rats breed in abundance. Therefore, when you take the history with acute febrile illness, contact history and their social histories are very important because to think about the leptospirosis as one of the differential diagnoses. The common places where the rats are populated prone to get this infection. High risk population, mainly the occupation and recreational activity, household exposures and others. The farmers prone to get the infection because they exposed to muddy water and muddy land. They prone to get this infection where the rats population are high, and contact with the animals prone to get, and working in sewerage system they prone to get this infection, and recreational activities also prone to get this infection. Working in poultry farm, right. Therefore, the high suspicion is very important when anyone comes with acute febrile illness, usually less than 3 to 7 days of fever. They can come with clinical features like subclinical features or sometimes fatal multi-organ failure features. The incubation period usually 3 days to 3 weeks. The common symptom, sudden onset of fever, myalgia, headache, and rigor. Less common, non-productive cough, sometimes diarrhea, nausea, vomiting, joint and bone pain, sore throat, and abdominal pain. Signs: always look the conjunctiva, it become red, conjunctival suffusion we call, and icteric, and check the muscles, mainly in the thigh muscles, you get tenderness, or in back muscles tenderness. On examination of the abdomen, there may be splenomegaly and hepatomegaly, evidence of pharyngitis and skin rashes. These rashes usually last 24 to 48 hours. It can occur in the soft palate or in the body. Usually purpuric rash, it colors change from red, brown or purple color, and hemorrhagic manifestation. This is a typical conjunctival suffusion, redness of the eye. You notice, always check that. This patient has the features of yellow discoloration of the sclera and conjunctival hemorrhage. This is a rash, purpuric rash, usually color purplish or reddish or sometimes brown discoloration, last 24 to 48 hours. Now, leptospirosis has two phases. One is, usually we call biphasic, with bacteremic phase as well as immune phase. During the bacteremic phase, the organism proliferate and disseminate throughout the body, causing direct damage to the tissue. Second phase, called immune phase, is marked by production of antibodies, mainly IgM antibody in the blood. At time the leptospira organism is cleared from the most of the site of the body, but tissue damage continue due to the immune mechanism. There are two phasic, biphasic illness. First, bacteremic phase, then immune phase. During the bacteremic phase, it can affect liver and other organ as well. Renal involvement is main problem. Therefore, anyone admitted with a fever, either dengue fever or leptospirosis or any fever, the input-output chart maintenance is very important to find out renal involvement early. When the reduced urine output, we have to act quickly and correct the renal output and maintain the vitals. They can come with hematuria. On examination of the urine, you may see granular cast and rectal cast. And then they can present with acute kidney injury with any degree of renal failure, the rising creatinine. Liver involvement is the commonest involvement in leptospirosis. They can present with jaundice. On abdominal examination, tend to hepatomegaly, rise in serum aspirate transaminase or alanine transaminase 3 times above the upper limit of normal. Then you may notice the raised serum bilirubin, alkaline phosphatase, and gamma PT. Sometimes prolonged prothrombin time also possible. The second common site, pulmonary involvement. This is the important problem in leptospirosis, causing a lot of death. They can present with cough and short of breath and hemoptysis, decreasing saturation. Therefore, suspected leptospirosis, the vital signs monitoring is very important. Mainly saturation, respiratory rate, blood pressure, pulse rate, urine output, and level of consciousness. If the saturation dropping less than 90% in room temperature air, you have to suspect pulmonary involvement. On examination, you may get crackles or wheeze. Evidence of lung parenchymal involvement you can see in chest X-ray or CT scan. It end up in acute respiratory distress syndrome, may need ventilator support. It can cause severe vasculitis and severe pulmonary hemorrhage may develop. That is the difficult condition to treat. Usually, we manage rather than intubation, better to manage NIV to maintain saturation is better. If we try to intubate and you may get severe bleeding, sometimes we encounter. Difficult to control the bleeding due to severe vasculitis. Cardiac involvement, usually they present with short of breath, chest pain, palpitation, tachycardia, and basal crackles. Blood pressure start to drop. ECG may show abnormalities, arrhythmias, STT changes, conduction abnormalities, and echocardiogram reveal wall motion abnormalities. Then they want to get myocarditis, pericarditis. Therefore, any patients, in the management point of view, the vitals are very important. We can detect. No one dies suddenly due to cardiac arrest. One of the important vitals, either blood pressure or saturation or pulse rate or urine output or level of consciousness, usually show some abnormality 3 or 4 hours prior to the bad effect. Therefore, the monitoring of patients very, very important, especially in patients with acute febrile illness in Sri Lanka, mainly dengue fever, typhus, leptospirosis, melioidosis. Every infections are fatal. Therefore, vital signs monitoring is very important part of the management. We can detect early detection and treat appropriately. We can reduce the mortality. Other important features, it affect the blood, hematological involvement, bleeding manifestation. They prone to get thrombocytopenia. Sometimes they develop disseminated intravascular hemolysis. Neurological involvement, reduced level of consciousness, features of meningitis, sometimes focal neurological sign. Therefore, if you suspect clinically leptospirosis, always the vital signs monitoring very important. That is a very important take-home message. When you see the patient or manage, that vitals monitoring very important. When you suspected leptospirosis clinically, we do investigations, full blood count. Usually you get leukocytosis and urine full report analysis gives some idea, proteinuria, hematuria, HAST. CPK may be high. Liver function test, usually ALT, AST is markedly raised and alkaline phosphatase, bilirubin high. Serum electrolytes, you get if you get hyperkalemia, patient with renal involvement, that is a bad prognostic factor. Therefore, continuous serum electrolytes monitoring is very important. And renal function measured by blood urea, creatinine, and calculate estimated GFR. If you suspect any cardiac involvement, ECG, and saturation drop less than 94, 95, urgent chest X-ray is very important. And active management we have to start to prevent the mortality. The chest X-ray is one patient admitted to our ward, severe difficulty in breathing on the day of admissions. Chest X-ray shows like this diffuse, ill-defined patchy lesions, mainly peripheral. You make it looks, it may be pulmonary hemorrhage, alveolar hemorrhage, or ARDS, or you may suspect pulmonary edema. But saturation drop and FiO2 partial pressure of oxygen ratios less than 200, everything more favor due to leptospirosis, infiltration, and ultimate ARDS. We can't allow to reach this patient when you get the patient. We start active management as early as possible. Anyone admitted with high fever, acute febrile illness, high index of suspicion important, occupational history gives some idea, and the full blood counts, leukocytosis, high ESR, liver involvement, renal involvement, and thrombocytopenia, always you suspect leptospirosis. If patients come within 6 days or 7 days, the organism we can identify by doing blood or CSF or urine analysis. If it comes later, after 7 days, we do serology, microscopic agglutination test, MAT test, or simple ELISA test or immunosorbent. Molecular test, PCR, also useful to diagnose. Isolation of leptospirosis, blood culture for leptospirosis is important. If patient come within 7 days, with high suspicion, you take blood culture. Gold standard test, requires samples during the first week of illness, used for identification of serovar and for determining the antibiotic sensitivity test. Is problem in our setup, but academic purpose we can do it. Polymerase chain reaction PCR, real-time PCR, useful for the early diagnosis, first week of acute illness, high sensitivity and specificity, useful for the genomic classification as well. Dark ground microscopy of body fluids, low sensitivity, we don't do now. Other test is a serological test. After 7 days or 6 days, we can do this test. Antibodies are usually detectable by day 6, 10 of illness. The peak within 3 to 4 weeks. The comparison of acute and convalescent have a high sensitivity and specificity can be used for the genus of serogroup identification. Microscopic MET test, microscopic agglutination test is a serological reference standard. However, requires experienced observer to reduce the interobserver variation. Time consuming and hazardous as a live culture are required to provide antigen available only in reference laboratory, may be available in MRI. The IgM enzyme linked immunosorbent assay ELISA test easily available. Sensitivity and specificity depend on the regional pattern of seropositivity. So ELISA test we can do in hospital setup, or if sample we can send to MRI and get it right. In the management part, you suspect patient leptospirosis, and if patient come within 4 to 7 days, we take the cultures, urine or blood or CSF analysis. After 7 days, we do ELISA antibody test. Then we have to start management immediately when you suspect any patient with leptospirosis. The management consists treatment and prevention. Treatment, there are a lot of options available. Penicillin group of drugs. Penicillin is an ideal drug to kill the organism. 2 mega units 6 hourly. If patient is allergic to penicillin, we can use hepazoline 1 gram IV daily or 1 gram IV BD. Doxycycline is a good drug, but we can't use in children under 12 years and pregnant ladies. 100 milligram 2 times per day for 7 days. And azithromycin is useful in pregnant ladies and children, 500 milligram daily for 7 days. Now, patient, when we see leptospirosis, they prone to get complication if not treated early with appropriate antibiotics. They can develop renal failure, acute kidney injury, uveitis, pulmonary hemorrhage. The pulmonary hemorrhage or pulmonary involvement we can detect by vitals monitoring, mainly saturation. When saturation drop less than 94, 95, always do urgent X-rays and start active treatment. We come later. ARDS is a treatment patient need ICU setup treatment. Myocarditis, they can develop rhabdomyolysis, very high CPK and causing renal involvement, electrolytes imbalance, and vasculitis. This is a problem. Vasculitis, pulmonary vasculitis, they prone to bleed into the lungs and causing difficulty in breathing and dropping saturations and difficult to manage. When you suspected vasculitis, pulmonary involvement, we have to start steroid high dose 1 gram methylprednisolone daily for at least 3 days, then put on oral prednisolone 1 milligram per kilogram per day at least 7 to 10 days. Otherwise, difficult to prevent the death. Liver failure, they may go into acute liver failure as well. And some people develop meningitis, aseptic meningitis. Right. When you see the patient in the ward, you manage daily vitals monitoring, appropriate antibiotic, hydration, everything provided. But when the patients deteriorate, we have to send the patient for further management in intensive care unit. Which type of patient we going to transfer ICU? One is hemodynamically instability. Tachycardia or bradycardia, pulse rate more than 110 or less than 50, or evidence of arrhythmia, or hypertension not responding adequate fluid resuscitation, systolic blood pressure less than 90, or mean arterial pressure less than 65, or 20% drop from the baseline of the blood pressure. About his blood pressure on admission 120, now drop to 90, that is significant. Then that patient, we give fluid boluses, then we start inotrope. That patient need ICU care. Evidence of poor peripheral circulation, capillary refilling time more than 2 seconds. These all indicate hemodynamic instability. Other indication for the ICU care, impaired oxygen, lung involvement, saturation. If dropping saturation less than 92, even with oxygen, patient should be transferred to ICU for the care. Or respiratory rate more than 30. If patient 1 year, less than 1 year, more than 60, or 1 to 12 years, more than 40, they should manage in the ICU setup. Here we use the patient's rule of 30 is commonly we use. Very useful. Any patient, acute illness, multi-organ involvement, rule of 30. 30, especially any blood loss or dengue patient or any acute febrile illness, multi-organ involvement, rule of 30. 30, one is respiratory rate more than 30, or pulse pressure drop less than 30, or urine output drop less than 30 ml per minute, or the blood pressure, systolic pressure drop by 30 from the baseline, or PCV drop less than 30 due to bleeding or something. The rule of 30 is very useful in management of febrile patients, especially dengue and leptospirosis, or any bleeding disorders. We can use this rule of 30. And evidence of pulmonary hemorrhage on chest X-rays or HRCT, acute respiratory distress syndrome features, where the partial pressure oxygen divided by FiO2 less than 200, that is important, we have to transfer to ICU. Significant spontaneous bleeding, either pulmonary bleeding or any other bleeding, we should transfer, or reduced level of consciousness. The Glasgow Coma scale is decreasing continuously, we have to transfer. Any other life-threatening complications, any evidence of organ dysfunction, severe sepsis, we should transfer the patient. Therefore, any patient who managed in the ward acute febrile illness, leptospirosis or dengue or any febrile illness, the vital monitoring is very, very important, and detect early and act quickly, and necessary, you have to consult with the ICU consultant and transfer the patient to ICU for further management. Right. In the management for leptospirosis, there are so many drugs available. We are confusing which drug we are going to use. There are studies. 2 randomized trials have compared the penicillin with ceftriaxone, 1 gram every 24 hours, or cefotaxime, 1 gram every 6 hours, or doxycycline, 100 milligram every 12 hours. All regimes were observed to be therapeutically equivalent in one randomized trial of 264 patients with severe leptospirosis in northeastern Thailand, comparing cefotaxime, penicillin, and doxycycline. All the regime had similar efficacy for leptospirosis. Therefore, leptospirosis, we can use either penicillin or doxycycline or cefotaxime. If patient is severe vomiting, better to use IV preparation. Among these patients, 132 patients were diagnosed with the rickettsial infection. For these patients, treatment with doxycycline was superior to the treatment with penicillin G. Therefore, doxycycline or cefotaxime or ceftriaxone are appropriate therapy for the treatment of severely ill patients in area endemic for leptospirosis and rickettsial infection. In Sri Lanka, southern part of the Sri Lanka and north central province is common with leptospirosis. Therefore, better to use IV drugs, cefotaxime or ceftriaxone. Azithromycin and doxycycline have comparable clinical efficacy. Azithromycin is better tolerated than doxycycline, but it's more expensive and less readily available. Therefore, we used to give doxycycline, but don't give under 12 years and pregnant lady. Patient with leptospirosis, it can affect any organ in the body, and early detection of complication is very important. The main part in the management, mainly respiratory tract involvement with pulmonary hemorrhage, where we use IV methylprednisolone. 1 gram daily for 3 days and 1 milligram per kilogram per day for 7 to 10 days we have to give. If patient develop renal involvement, acute kidney injury, usually patient need hemodialysis every other day and control the disease. The acute tubular necrosis recover gradually over the 2 to 3 weeks. And patient with DIC, if they are platelets low, less than 50,000 with bleeding manifestation, sometimes we have to give platelet transfusion. Usually we give 5 units of platelet concentrate. If the prothrombin time INR is prolonged, we have to give, in the bleeding patients, we have to give presprosin plasma. Usually we give 15 ml per kilo and monitor the prothrombin time INR and APTT. According to that, adjust the daily requirement of this blood product. If fibrinogen content is very low with the DIC, we have to give fibrinogen concentrate or cryoprecipitate to manage the DIC part. And management of heart problem, carditis. Some people use steroid, but no clear evidence. But patient needs intensive care unit management and support management. The patient with cardiac involvement, low blood pressure, we can use noradrenaline or dobutamine to maintain the blood pressure. And patient with acute liver failure management, important, low salt and standard management of acute liver failure treatment, and bowel opening 2 to 3 times per day. Sometimes we give lactulose, and sometimes we give to maintain the or reduce the prothrombin time by FFB. Vitamin K, 1 dose is enough, and using NAC, N-acetylcysteine, is a controversy. Some people use NAC, but volume management is very important in acute liver failure. Therefore, anyone come to the fever, occupational history is very important. If you suspect leptospirosis, take blood if culture or urine if comes up with it before 7 days, or after 7 days you do antibody and start appropriate antibiotics and observe the vitals and detect complication early and manage appropriately, and if necessary transfer the patient to ICU. Prevention of leptospirosis, next thing we're going to look through avoidance of potential exposure to the infection. Administration of pharmacological prophylaxis to individual at high risk people. We can use doxycycline 200 milligram weekly, commencing 1 week prior to the exposure and continued through the period of exposure is recommended. No human vaccine currently available. Now, in our country, acute febrile illness problem very common. About 30 to 40% of admission daily in the medical wards with the fevers. Therefore, adequate history is very important. Occupational history very important. Contact history is important, because all the acute febrile illness causing infection, mainly dengue fever, leptospirosis, melioidosis, typhus, If not treated early, they're going to give multi-organ problem and increase the mortality. Therefore, high suspicion of disease is very important, mainly leptospirosis. It's a curable disease if you treat early. And awareness of population is very important. In high endemic area, sometimes we advise to use prophylactic drugs also. Thank you for listening. The main features or take-home message: anyone come with acute febrile illness, high suspicion of leptospirosis is very important, and it is treatable disease. There are antibiotics available, and patient with the lung involvement, presence of pleural effusion, unlikely due to leptospirosis. You have to suspect other disease. Mainly in our setup, dengue, you have to suspect. Normally, in patient with leptospirosis lung involvement, pleural effusions less likely. The cardiac biomarkers that we do in suspected myocarditis, troponin, and other things, cardiac biomarkers are not helpful to diagnose cardiac involvement. And NAC, N-acetylcysteine, may be used in acute liver failure. The presence of hyperkalemia, high potassium, is uncommon in leptospirosis. Its presence indicates the prognosis is poor. Therefore, every doctors who treating your febrile patients, the management of leptospirosis, monitoring of the vitals, very, very important. Very simple, advise the nurses and house officers to monitor certain things in hourly basis or 2-3 hourly basis. And important message: no one develop cardiac arrest suddenly. Either one of the vitals deteriorate first. If you find out and correct at the time, we can prevent further complication. Thank you very much for the listening.
All right. Thank you so much, Dr. Peranantharajah, for giving us that wonderful lecture on leptospirosis. It was very informative, very well organized, and we learned quite a lot, and it refreshed a lot from our good olden medical school days, as well as our past experiences with patients with leptospirosis. So, and also here, once again, I would like to express our heartfelt gratitude on behalf of Shri for spending your valuable time with us. And also at this point, I would like to mention the Sri Lanka College of Internal Medicine for joining with Shri for this joint venture of this lecture today, this webinar. So thank you very much, SLCIM as well. So now that we have come to the end of our lecture, you can, the participants can put your questions in our chat box. And we've already received quite a lot of questions, sir. Now, with your permission, I would like to post a question so that our participants can get some answers from you. The first question that we received from one of our participants is this: can a patient develop leptospirosis for the second time in his life? That's a question, sir.
Good question.
Yes, sir.
So far, we didn't experience of second attack of leptospirosis, but the antibodies developed it last longer period. I am not sure to conclude the answer. Second occurrence of disease not possible.
Yes,
we
sir.
have to get some immunologist input to these questions. I'll let you know later after discussing with the immunologist and microbiologist and the epidemiologist people whether they have the experience of second attack. But dengue come third, fourth attack.
Yes, sir. All right. So thank you for that answer, sir. So we will be expecting a detailed answer with further input from the rest of the specialists. And we have another question regarding this is actually regarding prophylaxis of leptospirosis. Sir. So we know that in pregnancy, doxycycline is contraindicated. So in case a pregnant lady should go on prophylactic antibiotics, what should be is there a particular regime for that, or is there a choice of antibiotic?
Yeah, whatever we use in leptospirosis, azithromycin, we can give as a prophylactic 500 milligram
Yes, sir.
weekly
In
basis.
all right, sir. And we are getting more and more questions, and this is actually regarding the complications of leptospirosis. We know that pulmonary hemorrhages are a dreaded complication of leptospirosis, severe leptospirosis. So our participants would like to know how common this pulmonary. We know that it is a severe complication, but not all patients with leptospirosis develop pulmonary hemorrhages. Therefore, are there specific serotypes that are responsible for this developing pulmonary hemorrhages, sir?
If they come to hospital late, the immune reactions is developed. The immune phase develop. When
Yes.
the immune phase develop, they prone to get vasculitis, mainly pulmonary vasculitis. They prone to get bleeding. We had the last 2 months time, two patients. We had fever, typical leptospirosis. They came 5th day, 6 days. Anyhow, we started treatment. In the middle of the night, they started found blood, hemoptysis, frank blood. Then the saturation dropped. We managed with oxygen, and later we planned to intubate.
Yes.
During the intubation, full of blood, suck out blood continuously, and ultimately we put the tube. Unfortunately, we couldn't save the patient. Then we discussed with the intensivist in the ICU consultant. He advised rather than putting the in endotracheal tube and ventilate, better to manage with non-invasive type of ventilation. It's better to avoid the massive bleeding because by introducing the trocar and introducing the endotracheal tube, they prone to get massive bleeding and difficult to manage. We had lost two patients recently, both severe pulmonary hemorrhage. They came late. The same day on admission, we started treatment. We started methylprednisolone, but middle of the night they developed severe pulmonary hemorrhage. It's about 1 or 2% of the population that patient with leptospirosis. The immune reaction, therefore
Yes.
we have to give steroid.
Yes, sir. So that means patients who are coming in the immune phase of the illness, the late presentations, those patients are at higher risk for developing pulmonary hemorrhages.
Yes.
All right, sir. And we have some more questions, sir. Now, in your lecture, sir, you mentioned several antibiotics that can be used to treat leptospirosis, but is there drug of choice that we generally use? And with your clinical experience, sir, is there any resistance developing to certain antibiotics that we usually use, especially like
We didn't get any experience of resistance. But patient doxycycline in moderate leptospirosis is good, but some people develop severe vomiting due to the doxycycline. The patient develop vomiting, better to start intravenous preparation, ceftriaxone 1 gram daily enough, or cefotaxime 1 gram 6 hourly, or benzoyl penicillin 2 mega unit 6 hourly, if not allergic to penicillin. If allergic to penicillin, ceftriaxone, cefotaxime is ideal. But the development of immune and other reaction and other things almost same in all antibiotics used.
Yes.
Some people develop severe vomiting due to doxycycline.
Doxycycline. So for patients who develop this severe vomiting, intravenous, this third generation cephalosporins, those are a better option, intravenous therapy. Yes. And regarding the tests, microbiological and the biochemical tests that we do, sir. Now you mentioned the blood culture is like the gold standard that we can do, and we can do PCR and those tests to confirm. Are there like restrictions in the country where we can do certain immunological testing, sir? Are there specialized centers that where we have to send the samples to get a confirmation of this leptospira infections?
Yes, when we have high suspicion of leptospirosis, this culture demonstrate the organism.
Yes.
It is a direct detection method. Isolation of leptospira in CSF or blood or urine, that should take before 7 days. If they come late, that is usually not useful.
Yes.
And in our country setup, difficult to get that test also. Our setup, antibody test is ideal. We can do in MRI and available in private sector also. The MET test is very useful. The microscopic agglutination test,
Yes.
with more than 1 in 320 ratio of the titer, 1:320, the diagnostic, and fourfold rise after 4 weeks also confirm the test diagnosis. And ELISA test is a rapid test. In some university microbiology department, they have that. We can use that to detect. That is a rapid diagnostic method. 5 ml blood or 2 ml serum in sterile bottle, you send to the lab, they will do the ELISA test and detect. The serological test, MAT test, that is antibody detection by doing MAT, microscopic agglutination test. Other one, ELISA. ELISA is freely available.
All right, sir. So those are that is regarding the diagnostic tests of leptospirosis. And again, we have a question regarding pulmonary hemorrhages, sir. That is the management of pulmonary hemorrhages. One of our participants would like to know regarding now, if we consider these two options, intravenous immunoglobulin versus therapeutic plasma exchange. With your experience, what is generally, because it's an immune-mediated thing, out of IVIG and TPE, for which do our patients generally respond better?
And there are some centers, especially in Anuradhapura, they had the experience plasmapheresis.
Yes, sir.
Very useful in severe pulmonary involvement with vasculitis. In addition to the IV methylprednisolone, we can give immunoglobulin, IV immunoglobulin, or plasmapheresis. But
Yes.
plasmapheresis is not available in every centers. But sometimes we do intermittent plasmapheresis. Take the blood and centrifuge and retransfuse the red cells and take out the plasma, and another plasma we give it to the patient. We usually do in Guillain-Barré earlier time.
Yes.
Now, depend on the disease, the availability, everything. You see the pyramid of the management, the bottom. So a lot of people, when we use certain measures, very useful. Approach is different, but ultimate outcome is same. If
Yes.
facilities available, plasmapheresis, 4 hours plasmapheresis daily or every other day is maybe useful in patient with severe vasculitis and pulmonary hemorrhage, in addition to IV.
Yes, sir. So, so in the interest of time, we'll conclude with one last question, sir. That is regarding the place of steroids. What is the role of steroids in the management of leptospirosis?
Right. In management of leptospirosis, mainly the pulmonary involvement. You may get severe ARDS type of picture, pulmonary infiltrate. That time with the low saturation, the IV methylprednisolone will helpful. It salvage some patient with giving their drug, and severe vasculitis with pulmonary hemorrhage, useful.
Yes.
These are the two places we use. Other involvement, especially kidney, we can manage with the dialysis and control the antigen by giving the antibiotics. If liver failure, some people severe acute fulminant liver failure, NEC may be useful, but there are no clear evidence. But in our country, we are using NEC. In addition, plasmapheresis also they are trying to treat the acute liver failure and severe pulmonary hemorrhage.
All right, sir. So thank you so much for your kind answers, sir. I think our participants got to know, got their answers for these questions. And I would like to give a reminder to all of our participants that if you do have any other questions, you can forward those questions to this email address, officeshri13@gmail.com, and we will be sending you the answers in writing. So once again, thank you so much, sir, for taking time out of your busy schedule and giving us a wonderful lecture today. And I hope we all learned a lot. And also, we once again thank you so much, Sri, as well as the Sri Lanka College of Internal Medicine. So one last reminder for all the participants, we would value your feedback regarding today's lecture. So you will be getting a link in the chat as to how you can forward the feedback to us, and you will get the link to obtain the certificate of participation as well. So now we are going to conclude today's webinar, and we will hope your enthusiastic participation for our next seminar, which will be held on next Sunday. So thank you so much once again, and enjoy the rest of your weekend.